Hi, all. Thanks so much for watching Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta, and today we are welcoming three amazing guests. So we have Gina Hofert, who is the CEO of the Suda Institute, Dr. Russell Suda, who is the Chief Medical Officer of the Sun Project, and Dr. Bobby Levy, who is the Primary Care Addiction Medicine Program Director for Advocate Health. Thank you all for being here. Porv has met with Gina before and was so struck by what a loving organization the Suda Institute is. So before we start, why don't you tell the audience what is the Suda Institute, what's your mission, and what are some of those loving practices that you put into place there?
So the Suda Institute is the nonprofit that actually supports the Sun Clinic, which is the perinatal substance use disorder clinic here in the Cabarrus, Stanley, Rowan County areas in North Carolina. Our work really focuses on improving maternal and infant health by coordinating care across healthcare, behavioral health, social services for pregnant and postpartum individuals who are affected by substance use disorder. And we really focus on reducing stigma, being able to strengthen families so that moms can be able to receive the care that they need to support their health and stay together when it's safe to be able to do so. We really focus on fostering those relationships with mom and addressing those social determinants of health. So we believe that they need more than just medical care to be able to be good mamas. And so that's when we wrap around them in a loving way and help address those needs.
I guess I'll jump in from there, Gina. And maybe this question, as I think you had alluded in the pre-interview, may go to Dr. Suda and Dr. Levy because it's the relationship-centered part of the care that really makes Suda Institute stand out. And I guess, we want to just unpack all of that for our viewers. What is that? What does that look like? Where did it come from? Why are you folks such great believers in it? How does it look like on a day-to-day basis in the clinic and at the institute? And we'll go from there. I guess I already am so excited. I have layers of questions, but let's just start with the relationship-centered piece. And maybe we can start with you, Dr. Suda, and then Dr. Levy.
Yes. Well, I appreciate it, Dr. Gupta. And I think it's marvelous what you're putting together for the discipline of medicine. Because in my own life, as you were talking about going from burnout to compassion, I looked at my own life and I realized back from 81 to 85, I was at Hopkins every other night call for much of my residency, 36 hours on, 12 hours off, and barely survived that 4 years. And then I went into academic medicine and I tried academic medicine, basic research, and found that I really wasn't called to that. I didn't, even though I came out of Hopkins and I did a path residency before that, I said, this isn't what I want. So I left and I got into private practice and I spent 12 years of every other night call with a good friend of mine in the state of Washington seeing patients. And really not having enough time to really create strong relationships with my patients because I was always in the hospital or always trying to recover from being in the hospital. But by 2003, 2004, I told my wife, I said, I'm tired of this life. We're going on and I want you to follow your calling, which was music. And so we came back to North Carolina from the state of Washington. We're both from east of the Mississippi. I got into public health just simply because my wife had a job here and I took a public health job because they were looking for a medical director. I worked there. I've been working there for now 21 years. Now, the first 10 to 12 years, I was doing obstetrics and delivering babies and teaching family practice residents. I was very, very busy. And when the health director asked me to become the OB champion for the three counties, which is Rowan, Stanley, and Cabarrus County, in the primary care medical home model of obstetrics, I didn't want it. He said I had to take it. I took it, and I became ensconced with the fact that we were writing up clinical pathways on very difficult areas of obstetrics. Preterm delivery, growth restriction, cervical insufficiency, hypertension in pregnancy. But the one that blew us all away was substance use in pregnancy. Substance use in pregnancy took over a year to put that together. It was 21 pages long. as opposed to 3 to 4 for all the other pathways. It required complex, a coordination of care at the behavioral health level, social service level, obstetrical medical level. And I realized why all these years I didn't want to manage these patients because I didn't have the skill set or the comprehensive, particularly psychosocial skills to manage the more complex problems because their obstetrical problems weren't not that problematic. So what happened was, after the clinical pathway came out, I stumbled into 3 years of going out and looking at our community and seeing if anybody would be interested in joining a collaborative to put together all the elements that are necessary to coordinate and integrate the care of a very complex substance use perinatal patient. I got a lot of positive reviews, but I'm not an organizational skill guy. I'm just not. So in 2018, I met with a lady who helped me get some money. We hired Gina as the CEO, and we took off in 2019. Interestingly enough, I was very busy, but in July of 2018, I retired from hospital work. I gave up my hospital privileges, and now I could really look at these more difficult patients. I spent a lot of time working with our clinic culture and our organizational policies to to go over to taking care of substance use patients in pregnancy. That was no easy deal. But as we began to do it, I found out that as I cultivated my relationship with substance use disorder perinatal patients, I became empathetic. I mean, I really cared about what they were doing. I would go home at night and think about patients and what I could do for them. I never did that. I mean, it was like go home, get to bed, and get ready to go action time the next day. So, over the course of 6, 7 years now, since 2019 is when Gina joined us and led the organizational cross-sectoral work that took us where we're going. Um, we've managed over 100 patients with substance use disorder and perinatal settings. And I can't tell you the relationships that have been struck up. I've got a licensed clinical social worker walking in lockstep with me, peer recovery support person. I got all the tools. And once I had the tools and the institute gave me the time, I began to love my patients. I mean, I never did dislike them, but I didn't have time to start trying to establish any kind of emotive relationship with a patient. It just wasn't time. So, what I really like about my life right now, and I never thought I could be more excited about being a physician when I was doing urologic surgery, doing high risk obstetrics and interesting deliveries. I've superseded all those impressions in my life by being able to work in a very empathetic, compassionate way with women who really appreciate it once you can develop a trusting relationship with them. So, and we had a nice Echo Project presentation this morning, advancing, my skill set and the skill set of the providers who were dialed in on how to look at care from the patient's perspective. And when you look at care from the patient's perspective in a substance use disorder setting, these are very, very fragile patients, very, very willing to run at a moment's notice as soon as they don't feel safe. And I have learned so much, by taking on their perspective, telling them how great a mother they are for coming in. You are one courageous woman. Year after birth, that first year is very, very fragile for them women. Their care, they go to a RISE clinic. We just developed a RISE clinic, which is for men and women, either to the RISE clinic or the Cabarrus Family Medicine. Now that we have the facility and the coordination in place, it's really very exciting to do this work. Well, now that I don't have a rigorous scheduling of hospital-based activities, and because the Cabarrus Health Alliance is very understanding about having to spend more time with certain patients under certain circumstances, and having a licensed clinical social worker and peer recovery support person working with me, I've got all the tools I need to manage this population when beforehand I didn't have the tools or the time. And that's precisely why, to this day, obstetricians have struggled like the Dickens managing these kind of patients because they require more time per person than an obstetrician has on a routine schedule when they're delivering babies, doing surgeries, and just barely able to keep up.
That is all so fascinating. You said so many things that were so great. First of all, I had a high risk pregnancy. I had preeclampsia that progressed to HELP, and my baby was born at 27 and 6. Now she's 10. Um,
Hopefully
so
doing real well.
she is, yes. You would never
That's
know. Her biggest concern is whether or not she got slime that she's going to get in trouble for. I hate slime.
excellent.
But everywhere, it's everywhere. But you said so many things through that. It struck me when you said I was always in the hospital or recovering from being in the hospital, because it sounds like something a patient would say. And so, it's that same parallel path that physicians are running to patients. And I don't know that either side really is thinking about that. Like, you consciously know that that's a human doing that same thing, but to have that awareness. And then you talked about several times being burned out and feeling, stressed, and you needed to change. And it was only after you retired that you had this revelation of how much care and how much you love working with this specific population. And you said that you never really thought about that. You said something like that, like you never really thought about that, or you never were involved to that degree. And we had an interview with another doctor, and I can't think of his name for the life of me right now, and it drives me nuts because I'm usually good at that. But he said the same thing because of the training that they had in medical school. He's, probably in your same age grouping, that was just not something that you thought of, that you were trained to do, to relate to the patients that way and to get to know them. And his daughter is now a doctor, and she had a totally different training and is, starting to see that change. So it's that same renaissance of care that you experienced in life. And it's clear that now in retirement, you seem to have more energy than ever. It's remarkable. So to both of you, all three of you, when you're dealing with this challenging patient population, and again, you alluded a lot to the trust that you have to build with them for various reasons. What is that like, trying to do that? And do you have mothers, I'm sure you probably do, who maybe have had children while they were dealing with substance use disorders prior to getting help from the Suda Institute and then working with you? And, what has their experience been like? How are you seeing lives change? Because it's got to be incredible.
Well, I see women who have, for the registration as a new OB patient, in the late first trimester or someone in the second trimester, who have taken fentanyl on the morning of coming in, and just to allay withdrawals, and we get them over the rocky road of getting them on buprenorphine in a week to 10 days. And then 5 months later, they're in to see me, and they're doting on their baby in a bassinet, and they're doting on their baby every bit as much as any other mother. And in fact, when I say to them, "Have you been using any illicits?" I just checking, and she goes, "So many." I say, "Nope, that's my drug over there, my little bassinet over there. That's my drug." And what's really amazing, when you leverage the love of a baby to a mother, the maternal spirit is alive and well. It just has to be uncorked. I mean, the maternal spirit is so ridiculously powerful. I've been brought to tears so many times when they do that. And I look at a mother who's like, now she's taking care of herself. Her hair is nicely combed. She's got some makeup on. She's happy. Even though she's got a lot of social challenges, and even some behavioral health challenges, she's got a baby that she can love. And that is a priori superseding all the other concerns she has in her life, which would blow me away if I had her social concerns. This ability to be an observer of this transformational change in a human being, and not worried so much about her relapsing. We have women who lapse in the first year of pregnancy after the delivery. that is not relapsing. That is lapsing. And if you stay with them and you reassure them and you say, look, I have a drink every once in a while, what the heck? You did that, but your mother came over and took care of the baby or the father. You're okay. You're still a great, great mother. And when I say that, you can see it just moves them. And I can't tell you how many women have said, I don't hear those words. Dr. Suda, that is so nice. Thank you. And it comes back to me, and it just motivates me more to be, to give them the adulation that they so greatly deserve. And the maternal spirit is, I would like to write a book about it. It's just amazing what you can see.
What you said there is just like, I think all of us are stunned. I don't know if Gina and Dr. Levy have heard this before, but just that power of the maternal spirit just needing to be uncorked, I think you said. Oh my goodness. I'm breathing that in. That's just unbelievable. So Dr. Levy, I'd invite you into this conversation and help us understand your perspective on relationships. How did you get connected into Gina and Dr. Suda? And if you want to kind of help us, understand how did these ideas, start to change for you, and how have you tried to bring them into the institute and into the clinics where you work?
Yeah, well, I think your listeners and you recognize why Dr. Suda is one of my mentors now, just listening to him speak for a few minutes. But, you know, there was a period at which Russ's practice involved taking care of patients through their pregnancy with substance use. But at about a year, they didn't necessarily have anywhere for those postpartum patients to go, and they were no longer pregnant or nearly postpartum, and so he was looking for a place to connect care. And coincidentally, I was also getting very interested in addiction medicine in the primary care space, and so we formed this great relationship whereby when those patients reached the 1 year mark, he handed them off to me. It was just a wonderful, delightful population to take care of. And yeah, just to Russ's point, it's so wonderful to see these stories of transformation and these loving mothers who really the addiction has become, background, and family and childcare have become forefront. And so through doing that, we continue to grow this relationship, and now have a relationship whereby at the end of pregnancy, because Russ, even though he still runs every morning and is still practicing at 74 years old, doesn't come into the hospital and deliver babies anymore. He hands them off to me in the third trimester, and me or one of my partners help deliver those patients, take care of them in the hospital, and that is now how the relationship has become. The best part of this by far is the adage that you and I learned in medical school, which is the patient is the teacher, just resonates every time you're with a patient in this circumstance. They are, when you develop the trust and when you take away the stigma and judgment that we tend to, use when we think about substance use, and we treat it like every other medical condition, patients just share so much with you. And the gift of them sharing that is an absolute burnout remedy. I mean, you just see the depth of relationship that we are able to have with patients in the perinatal substance use world is unlike any others. It really is.
Good point.
That's pretty incredible. I love how you talk so much about treating them like any other patient. And in many ways, the fact that now they have this, Dr. Suda, you're not practicing in a hospital anymore, so you're able to dedicate more time to them. And Dr. Levy, like you said, really manage that relationship with them. It's something that we heard actually probably the first year or two that we started doing Making Healthcare Work for You. We talked to a man named Leon Evans in San Antonio, Texas, and they created a program called the Mommies Program that was specifically for heroin addicted prostitutes. And they created their own clinic for them and treated it exactly like any other OBGYN patient. And he said the hope is what got them through. And those are the same things that I'm hearing now. So what are some of the actual ways that when they come see you, that you're treating these people, that you're caring for them in a way that they're not going to get in a different situation?
It's so interesting that you talked about that sort of generational difference between the doctor and his daughter, because the thing that we see, Stephanie, is our learners right now, and I'm part of Cabarrus Family Medicine residency program, so I train medical students and residents. Our learners right now basically talk to someone with a substance use disorder the way they talk to somebody with breast cancer or diabetes or heart disease. It is just like, hey, we know all about this condition. We know what helps it. We know the therapies. We know the, supportive care. We know what the follow-up looks like. We know what the rate of return to use is. And so we just talk about it in a much more, objective way. And then when you do it, it's like it's a no effort issue. Patients are like I've had so many patients say, I've never had a doctor talk to me this way. And I think you're about to, because all the rising generation gets it now. They just will treat you just like, the wonderful human being you are, with all the potential and hope and, dreams that all of our other patients have, to be healthy and to be connected. And so that's my take. Russ may have. You have anything else to add, Russ?
When I did a path residency, and this is not about me and me alone, but we did a tumor board thing. We brought all the specialists together, 8 of us around a table, and we throw a chart out there, and everybody would comment on what should be done for this cancer patient. Very complex patients who had also psychosocial issues because of their cancers. And I wanted that to apply in obstetrics because I saw the applicability. And now that I'm surrounded by a bunch of people who all have their part in this, as in the mosaic of care for this patient. I feel totally confident out there, where I didn't before. When I was alone, it was like, get out of my office. I can't take care of you. This is ridiculous. And most of them did leave because I was judgmental. And if you look at obstetrics nowadays, obstetricians are so ridiculously busy, and we're undernumbered terribly in the country. 45% of the counties in the United States don't have an obstetrician. So, it's not going to get better in the world of obstetrics. That's why Bobby Levy, I think, is opening up a tunnel of hope with a light at the end of that tunnel, where primary care, for some reason, can manage to do more and spend more time and be more efficacious with these patients than an obstetrician gynecologist. Because I know when I came out of Hopkins, I was programmed to work fast. And I was not programmed to sit there and coddle anybody. They talk that talk, but they didn't walk that walk. The walk was, you're working 36 and going home for 12, and you better be back here and hustling when you walk in the door. And so you're when you get primed in that kind of setting, you live like that for years. And it wasn't until, like I said, I went to public health, slowed me down. Retiring from hospital work slowed me down, and then getting into substance use, where I could spend the time in a slow down mode uh, to get to know my patients and do something for them.
In addition to time and being programmed to be sort of like an automaton and just go for speed, at some point that time released, and therefore you had more time, Dr. Suda. But at that point, you yourself described yourself as not a very empathetic type of a physician. So, is there anything else that happened to you at that time that allowed you to enter into that space of psychological safety, you might call it, or you might just call it vulnerability or just, presence. I don't know. Is there any other personal journey, inner journey, or something else that allowed both of you to kind of be in that space with these physicians? Dr. Levy, you said these are wonderful patients that he's passing on to you, whereas most other physicians would be like, I don't want them. So what I'd love to unpack a little bit more of is what really allowed both of you to enter into that space with these patients.
Having more time was part of it, but guilt did a lot of it too, because I felt bad about the way I treated these patients for years, because I openly admitted I did not have the wherewithal to manage these patients, and they were a threat to my license. And a lot of physicians, you know, idolize their license too much. I mean, we worry so much about a license, and yet we're licensed to help people. And my license was always right out in front of me because, I mean, everybody talked the talk too. I mean, the obstetricians always said, "I'm not managing that gal. She's on this drug and that drug. She's going to have a bad baby. I'm going to be out of work. I'm going to lose my license." So that was a strong motivator. Once I realized that wasn't really playing out, because I got to know patients, and there was nothing in the Journal of Substance Use and Abuse Treatment that I read for 6 years now ever about litigational problems with these patients. I mean, zero. Much more in the obstetric literature, but not in the substance abuse literature. Then I was able to calm down. And so guilt played a role.
Amazing insight. Oh my God. I could unpack that with you in another episode. I've never heard that before. So thank you for being a mentor to us as well on this show. Dr. Levy, would you add anything else to that?
Yeah, I mean, I think there's always been this friction in my early career around, how patients with substance use were treated. And on the one hand, you get part of this medical culture that you get raised in is to, give people the pull yourself up by your bootstraps talk. But then at some point, you realize maybe you need to give them a pair of boots. Like maybe you need to give them hope. Maybe you need to give them a chance. Maybe you need to understand where they are coming from. And I think, right around the time that this relationship formed with me and Russ is when a lot of the light bulbs came on, like, oh my gosh, I'm thinking about this all wrong. And all you do is spend a few minutes with a patient with the attitude shift away from judgment and towards empathy and compassion. And, it just like this, it flourishes. It flourishes. Yeah.
That's amazing. Dr. Suda, it was fascinating to me, and I mean, I'm speculating here, but you said that a lot of the litigation is in the obstetrics, but not in the substance use. And I would imagine there's trust issues, and they do have something on the line. Like you said, you've seen patients who used fentanyl the morning that they come see you. For them to go get a lawyer and then proactively seek out the legal system seems terrifying because, oh my God, well, what if they immediately say, well, you're doing fentanyl? That seems like that's so losing your license for engaging with the substance use group seems particularly unlikely, for the reasons that we just said. And Dr. Levy, to your point, whenever I worked at a company called Benefit Focus, the co-founder's name was Sean Jenkins. He's now doing another company, but he was talking to the sales team and he was saying, it's about develop your field. And he very likely may not have come up with this theory himself, but that's where I heard it. So in my case, Sean Jenkins gets this credit. But he said, you have the exact same things. You could be driving down a rural road, and on the left side, you have this beautiful farm with these lush fields and great crops. And on the other side, you have dead grass and nothing. But they've had the same water, the same sun, all the same things, but the way that the person tended to their field was different. So you have to develop your field. And in this case, this is exactly what you guys are doing. You're taking two patients that, they could have the exact same parallel lives, but when you put them in the condition and you develop those relationships and cultivate the hope in them, give them the boots, then you really have a different result and you can grow the crop and see the results that you have. And so it's remarkable what you're doing, and we really appreciate you all being here.
Well, I love the metaphor, Stephanie. Thank you.
Yes, very nice.
Unbelievable. Yeah, and I would feel remiss if we didn't give Gina at least a chance to come in with some thoughts, reflections. It's probably a hard act to follow with these two, Gina, at the same time. But any thoughts that are coming to you about what you are all working on together at the Suda Institute?
These are two remarkable men. I can remember when we first started, the one thing that stood out to me was Dr. Suda saying, I can do the medicine, but it's all the other things that I can't, and it was overwhelming to me. And so that was the whole ask of bringing a network together, and that he would try to call social services, or he would try to call the law enforcement agents, and they wouldn't talk to him. And he said, I can have the best 1 hour appointment with this patient, but as soon as she goes out into the other system partners and they undo what I do, or she can't get her medicines, I need a whole system that works together. And I think that that has really been transformational in our community, is having these two champions that not only do the work that they do within their fields, but then they go out and they champion this work in all of the other sectors. So we work really closely with social services, with law enforcement, with behavioral health, with the pharmacies, to ensure that all the touch points that these moms go to are getting that same trauma-informed care, are getting that same compassionate care, because all of us have to work together no matter where that mom goes across. And so that's part of the work of the Suda Institute, is making sure that it's holistically across the entire community.
Did you have any sort of resistance to that approach whenever you first started going out and saying, hey, we really need to do this and this can help them?
Years, 7 years of working, and we continue to have resistance. And our biggest obstacle was the legal framework that we had to put in place. There's a lot of laws that, for the sake of patient privacy, that we need, inadvertently create barriers to collaboration. So we had to overcome those first. Now that we have those in place, we have that, but then you get into fear and stigma. And so we've overcome some of those, but there's still a lot of resistance, but we've made a lot of headway, and we're really proud of that.
So I guess the final question, if we ask, what would you tell other communities that want to have these same types of results and foster these relationships? Where do people start? Because it does seem like it takes a lot of change and open-mindedness.
I would identify your champions, find your Dr. Sudas, find your Dr. Levy's, meet people where they are, both your patients, your providers. I used to get really frustrated with providers who wouldn't want to do the right thing, and recognizing that providers are just like our patients. And we need to meet people with love and compassion in their fields, in their recovery journey, no matter where they are, and move the community one step at a time. Here we are 7 years later, and I wish we were 10 years ahead. That's okay, we'll get there. And every year we move a little closer to where we want to be.
Amazing. Thank you all for being here and for this conversation. This was fantastic and enlightening, and I loved every second of it.
Thank you.
Thank you.
Inspiring.
Thank you for your work.
Thank you,
Thank
Dr.
you so
Gupta.
much. Oh, thank you so much. This is so inspiring.
Thank you all for watching. We'll talk to you soon. Bye-bye.
Right. Bye-bye.